Good afternoon. My name is Jack Laffin. I'm a cardiology registrar in Beaumont Hospital in Dublin, Ireland. Can you hear me, sir? I present a case of double culotte stenting in a circumflex marginal artery. I have no conflict of interest to declare. This is the case of an 81-year-old man who presented with exertional angina on a background history of hypertension and hyperlipidemia. Angiography revealed preserved left ventricular function, diffuse moderate disease in dominant right coronary artery, near separate ostia in a left coronary system with diffuse disease. So, can you hear me there?
Yeah.
Oh, sorry.
Come closer, maybe.
Sorry. Oh. Diffuse disease in an LAD with separate ostia to the circumflex, and high-grade disease in a large first marginal, second marginal, and distal AV circumflex. He had a cardiac MRI which showed a subtle subendocardial infarction in the lateral wall with preserved left ventricular function and ejection fraction of 62%. He had moderate inducible ischemia in the lateral, posterolateral and anterolateral walls from base to apex, and all territories were viable. So in summary, this was essentially single vessel disease. Functionally so, at least anyway. The decision was made to perform PCI to the circumflex. So we first wired the second marginal and the AV circumflex. Both with sine wires. Then using guideliner support, we pre-dilated the distal AV circ with a 2mm balloon, and a 2.5 by 20mm biomatrix alpha stent was deployed and post-dilated to 3mm. Second marginal was then pre-dilated with a 2.0 balloon, and then a 3.033 biomatrix alpha stent was deployed from the mid-circumflex to the second marginal. It's inflating here. The wires were then exchanged and the stent struts were crossed into the AV circ. Following proximal post-dilatation to 3.0 at high pressure, kissing balloon angioplasty was performed with 2.5 and 2.0 non-compliant balloons. Attention was then turned to the first marginal, and unfortunately this turned out to be a CTO. Many different CTO wire escalations were attempted and eventually crossed using anchor balloon support in the circumflex stent with a fine cross microcatheter. Unfortunately at this stage the system all fell out, and we had to recross the first marginal using a Corsair microcatheter and a fighter wire. There was concern about distal dissection that the angiogram was reassuring through the Corsair. This was then exchanged out with a trapper balloon for a Grand Slam wire, and we pre-dilated the first marginal with a 2.0 balloon and deployed a 2.5 by 30mm synergy stent from the proximal circumflex into the first marginal. We then approximately post-dilated this 3.5mm. Stent struts were then recrossed again, and a second culotte with a 3.5 by 28mm synergy from the ostium of the circumflex into within the stent in the mid-circumflex vessel was performed. This was post-dilated approximately to 4mm and then kissed with 3.0 and 2.5mm balloons. So a good example of complex angioplasty strategy for a single vessel disease with an excellent angiographic result. And that's just the final shot of the LAD, which is uninvolved. Thank you.
Thank you. That was a complex, very interesting case. So anyone from the floor would like to ask questions or comments? This is a double culotte.
Yeah, a culotte with the second marginal and then back up. Once we got the first marginal pre-dilated, then a culotte back from the ostium into the leg of the Y, I suppose, in the mid-circ.
And also on top of that, the obtuse marginal, the first one is actually a CTO.
Yeah.
So after dealing with the distal bifurcation with the culotte, you recanalized the CTO and did a second culotte.
Exactly, yeah.
On top of that.
Yeah.
Okay, great. Any comments?
So any preference? Let's just have a few minutes, since we have a few minutes to discuss. Any preference from any one of you, culotte versus double kiss crush, in this particular situation, or in general? Or
We can do a show of hands.
Yes. Yeah.
right?
So who would have preferred to do double culotte rather than double kiss crush? Well, in two areas. Culotte. Okay. How about double kiss crush? Okay, probably equal. How about Dr. Kao? What would you?
Well, I would prefer culotte because I think culotte will give you a very symmetrical distribution of metal in the proximal leg of the vessel, and it's almost 100% sure both of the ostiums are taken care of.
Okay.
While you are doing a crush, mini, or a tap, sometimes it's not that definite.
Yes.
And I would say in a case like this, I would use IVUS. I would use the IVUS from the beginning and for the final, because with all these kind of complex technique, you want to make sure that expansion of the stent struts is good. There is no bias of the flow divider, and also long segments of overlapping stents. You want to make sure the stents are well opposed.
Yes. Yes. So let me give you my humble opinion. Here, of course, the only downside that most people see with culotte is the double stenting in a longer area than tap or T, correct? Or the double kiss crush. So there is a longer segment where you have two stents, and there is maybe a bit more in some in vitro studies, maybe a bit more distortion of the stent, but I'm not sure if I would buy that. How about here? Do we have any area where you have three stents overlap? I mean, if you think about it, go back to the pictures.
Sorry, they're kind of stacked, so I'll have to just...
Well, yeah, let's rewind them. We still have a few minutes. We can discuss that.
No, there's no area where there should be three stents on top of each other.
So well, let's just
go
go
to the
through
very
the... And by the way, I like the way you worked through the guideliner the whole time. This was pretty challenging.
And who pulled the system out?
The patient coughed.
Okay. So your first culotte
You will have overlapping over here.
Yeah.
over here, but to what point?
To just I'll show you here to the mid. So that's
okay.
just pre-dilating the second marginal there, and that's the stent there coming. That's into the side branch first.
Right, and the other one has to.
Then comes down here.
Okay.
So it comes back. There's sorry, the previous video there. It's, the way they're stacked, I can't rewind them easily after this. But,
Yeah,
but it's coming to about here to the mid.
Yeah, or a bit higher. If you
Yeah.
look at where the
Yeah,
stent,
right.
if you go back to the previous picture,
Oh, sorry.
where at least you had the stent placed,
You can see that in the angiogram.
it's probably up to about here.
The marginal one, right? You are mentioning about the marginal.
Right,
Well, that's the
No,
one that goes back
but
further
the
is the one that
one-
goes into the distal circ. Yeah.
into the distal
Yeah,
circle.
yeah. It goes around the corner. Sorry, it's just the way they're stacked there.
Yeah.
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 See?
So, yeah, that's the one.
The one going to the
I'm
marginal.
talking about this
that,
one.
That one there is higher.
Talking about this one. This one is
Yeah, yeah.
right.
So there's two stents at that
So
stage.
this one
and
is
then the-
higher, and then when you go back, excuse me. So you have one that,
Sorry, just go back in.
yeah. Anyway, the bottom line, just go back to the next one. Well, stop right there. The bottom line is here you have two stents up to this point.
Yeah.
And if your second culotte, you have the stent coming to this point, then you have here three stents. Yeah.
Three
I mean,
layers.
it's just a possibility to be aware of, that's all. It's nothing wrong with it, but especially if you have the possibility of three stents, I think IVUS is fundamental there, because this will be a nidus of stent thrombosis, and you want to dilate this as much as possible. So all those little, I think, tricks are important. Any question at all? Okay, good. So I think we'll move to the next. This was very good. Thank you so much.